Remember that picture which I had showed you, the antigen presenting cell present to the lymphocyte, right? Then what happened? Yes, yes, go ahead. Just explain how the things are going on. Anybody from the class?
Assalamualaikum, doctor.
Yes, yes, please.
Doctor, I have a question, but not regarding the question itself. It's just the terms.
Mhm.
What's the difference between asking about pathogenesis and pathophysiology? So, like, what's the difference between them?
Almost is the same thing. It's the same thing. Now I am asking about that how this whole cascade is taking place. So as you are asking, I would like you to respond if you want to. No, no, it's up to you. If you say no, then I'll ask somebody else. If you have something in mind, go up. I want online students to be with me. So, I don't want that there should be a complaint that, online students were not involved in that. So I'll be happy if any of the online student will give this answer to me.
I don't mind answering the question.
Sure, go ahead. Go ahead.
Okay, so in this question, they're asking
Give
for
your
the.
name first, please.
My name is Basil Khatib.
Basit. Welcome, Basit. So go ahead.
Basil. Okay.
Basil, okay. Basil, go ahead.
So they're
Sorry.
asking about the pathogenesis of this lesion. So
Mhm.
we know that we're dealing with caseous type of inflammation or necrosis, caseous necrosis.
So,
So it is important to know the reason for the formation of the caseous necrosis is that the cell loses its cell structure, and because of the Langerhans cells and the giant cells
don't
that
say Langerhans.
yeah
Basil, Langerhans.
Langerhans.
Langerhans cells are different cells. Please don't confuse Langerhans cell with Langerhans cell, right? Go ahead.
And the Langerhans cells are basically eating up the cells, and what does that lead to? Because of the structure of the mycobacterium,
Mm-hmm.
have a rich lipid cell wall.
Mm-hmm. Good.
And when the macrophages or the giant cells and the epithelioid cells they attack these macrophages and break them down, it causes the formation of granules because of the secretion of
Granules, granuloma.
granulomas.
Yes. So how this macrophages are being activated?
Uh, because of the interferon gammas that are
Where
being
this interferon gamma coming from?
the lymphocytes.
Yes, very nice. So this is all pathogenesis which
And
you are telling me, right?
the T helper cells, T
Mm,
group, they also release interferon gamma, which also help activate the macrophages.
good. So this activated macrophages then they form.
uh, More epithelioid cells. Once they enter the tissue, they become
Mhm.
epithelioid cells, especially after being manifested inside the tissues for a long time, and they start breaking down these mycobacteriums, which leads to the granuloma.
Okay, good. Everybody is
Yeah.
satisfied with this answer, or you want to add something? Is okay, right? How long that epithelioid cell can live when it enters into the granuloma? Online. How long? Any student?
As long as it needs to.
Yes, because now they secrete some cytokine which does not allow these epithelioid cell to die. So it can remain there for months to even years until that granuloma is there. Now there is one simple question: why this granuloma is been formed? What is the advantage of having this granuloma? Okay, then what help do you get from this granuloma? Very good. So granuloma itself is a blessing so that it actually encloses that mycobacterium inside and it does not allow that mycobacterium to leave that particular area. Okay, good. Question number 3. What would a sputum sample show? Anybody? And he had to explain, or he or she had to explain how it looks like this one. So anybody from the class, from this group first? Yes, go ahead.
it will show positive for TB bacteria because we're using acid
Little
fast.
louder, please.
We're using acid fast stain, so TB bacteria will stain pink, and all
What's the
other
name of that acid fast stain?
listen.
Zeal Nielsen, right?
Zeal
Zeal
Nielsen.
Nielsen, ZN stain, right? Okay,
Yes.
go ahead.
So the TB bacteria will stain pink, and all other bacteria will stain blue.
How do you stain that Zeal Nielsen? What's the procedure of doing that?
You add
You
carbofusion.
make a smear first,
Yes.
then
Then add the carbofusion.
carbofustion on that, then
Yes. Decolorize it
how?
by adding alcohol.
No, no. You have put
Ethanol.
some carbofustion on it.
Yeah, we added
Then,
this.
then what you do? Heat it. For how much time? 2 to 3 minutes. You don't have to boil it, remember. When you see some steam is coming out, take out the lamp from there, right? And then you again put it there. Don't try to boil it, otherwise it will be dried on and the thing will be spoiled. So just you have to heat it, and then for 2 to 3 minutes, what will happen this heating? It will allow
Fix the bacteria.
it will allow
Fixation of the TB bacteria. And
yes, the wax layer of the mycobacteria will be relaxed, and it will allow the stain to go inside. Okay, what we'll do then?
then we add ethanol or alcohol.
Okay,
Decolorize
wash it to
yes.
decolorize it. Okay,
Then
then
add methylene blue.
what is the use of adding methylene blue?
It stains all other bacteria that doesn't have the lipid uh, structure. So it will stain all other bacteria in the background and show the TB as pink only.
Okay, the function of methylene blue is nothing but to give a contrast, not the bacteria, but the contrast of the whole surrounding area. So whole surrounding area become blue, and the bacteria will be easily been picked up pink. Okay, clear? Okay, any question from online student or any addition they want to make online? I'm not hearing from any girl from online. Only one Basil has jumped in, and I want other students to please kindly open their mics and be with us. Question number 4. Why does this patient have the systemic symptom of fever, sweats, and weight loss? Yes. Why does this patient has these symptoms?
About this question, we're not so sure because it's chronic inflammation. But our
Who
guess
is replying me? Raise hand. No, I don't want answer from you. I want somebody else to say. We have 6 students, and I want somebody else to join us. Don't shy, please. If you do mistake, I'm standing there to correct you. This is a very good opportunity to clear yourself here. If you say something wrong, your marks will not be deducted. At least you will clear your concepts. Yes.
So I think that PGE2, the tumor necrosis factor, and I think interleukin 1.
Very nice. So these cytokines will do what?
We're going to go to the hypothalamus. They will set the temperature. We're going to have a high temperature.
Okay, good, excellent.
And
Do you want to add anything? Same thing.
Yeah. Tumor necrosis factor. For the fever, they stimulate the prostaglandins A2 by COX. Stimulating the COX produce prostaglandins A2. This will reset the fever in the hypothalamus.
Good. So that's why. And weight loss?
Because
remember, there is less amount of secretion of tumor necrosis factor in chronic inflammation, but in tumor, they are secreting like anything. So you must have seen a cachexic patient. You know what is cachexia? muscle wasting. So they are so thin and lean because of this tumor necrosis factor, right? So this weight loss is because of that. Okay. So now we are going to start with case number 3.
Doctor, I have a question.
Yes, yes.
Why
Basil,
is it specific? No, not Basil. Salam Shaballu, another person.
please can you repeat your name?
Salam Shaballu.
Okay. So what's your question?
Why is it specifically night sweats? Why does it like a normal day function? Why doesn't he sweat?
Usually there are some specific clinical symptoms which you see in different diseases. In tuberculosis, this is specifically be in night sweating in these type of patients. Specifically, there are few things which you see and then you say that this is this disease. So this is specifically for tuberculosis that you see a night sweating on these patients. Okay.
So there's no mechanism of action behind it, no specific.
Probably it could be, but we are not going in that much detail, right?
Okay. Okay.
Now,
Thank you.
question number 3. Case number 3. Sorry. So you are going to present. Go ahead. Read. Yes. Go. Read the case first.
Okay. A 15-year-old girl had streptococcal pharyngitis 3 weeks ago. She now has low-grade fever, pleuritic chest pain, waxing and waning arthritis, and painful subcutaneous nodules. A friction rub is audible on chest auscultation. Her WBC count is 12,130, and her ESR is 30 millimeter per hour. Her anti-streptolysin O titer is 1 to 512. She suddenly dies of an apparent arrhythmia. Autopsy examination has been performed. Gross and microscopic images of the heart and pericardial sac are provided.
Okay. So question number 1. Describe the morphological pattern of inflammation in epicardium. Who's going to answer?
5% inflammation.
Sorry?
5% inflammation.
Fibrinous. Fibrinous inflammation. Why you are calling it fibrinous? Why? Because
it's pink in color. Accumulation of fibrin.
Accumulation of fibrin.
Yes.
Okay. Yeah. So what happens that, because there is a lot of inflammatory process going on, can you explain some pathogenesis?
Some pathogenesis.
How it happens? We'll do it later on, but something regarding, okay. In the next question, it is explain the pathophysiology of the disease. So how will you do the pathophysiology?
Okay, so we know. Okay, so we know in fibrinoid, it's all about fibrin. So in inflammation, we have a stimulation of the liver to synthesize more fibrinogen, and this fibrinogen will leak out into where we have the inflammation, because the capillary will be increased in permeability, vascular permeability, that will lead to increased fibrin in that area.
Do you know which case we are talking about? Means what this patient had?
Yeah, endocarditis.
Rheumatic fever.
Rheumatic fever.
So
Yeah.
what is rheumatic fever and how? This actually is a pathophysiology.
Yeah.
So what this rheumatic fever is up to? How it has been? Yes.
Okay, so we have streptococcal pharyngitis. We know the main cause of, or the most common cause of streptococcal pharyngitis is
Which streptococcus?
streptococcal pyogen.
Pyogen.
Pyogens, yeah.
Pyogens. Streptococcus pyogen.
It's a beta. It's a
Alpha.
It's a
Beta hemolytic.
Beta hemolytic.
group A beta hemolytic.
Group A beta hemolytic, yeah.
Streptococcus, right? Beta A
Hemolytic.
hemolyticus.
Yeah.
Streptococcus.
Yes.
Okay. What does it do?
Okay, so it has an M antigen.
Hmm.
So this M antigen, sure, the immune system will start secreting antibodies against these M antigens, and these antibodies will go and attack the heart muscle.
Okay.
Okay, so this will lead to the myocarditis.
Which part of the heart muscle?
Muscles?
Endocarditis.
Endocarditis.
So it will basically involve all the muscles, means endocarditis, myocarditis, and pericarditis.
Yes. Heart
Right?
muscles.
All the muscles. So the pericardium, because here it is a pericardial effusion. So this pericardium become inflamed. And what happens, as you were saying, that there will be more and more
fibrinogen.
permeability
Yeah.
in the pericardium. So what will happen?
Increase fibrin.
Fibrin will come out.
Yes.
And so this type of fibrinous inflammation is also called
Bread and butter.
bread and butter. Very nice, excellent. So bread and butter. Why we call it? Because when you peel up both of the bread, a meshwork, bread and butter mesh, it will just look like that. Okay, is it clear? Anybody have any question online, or
Yes,
anybody
doctor.
wants to add something?
Doctor, I have a question.
Sure.
How can we tell that fibroid inflammation when we can see it's wet, like there's fluid accumulation and so on?
Will you please say something loudly so that I can understand?
Yes. How did we know that it's fibroid inflammation and there's fluid there?
Which inflammation? Sorry. Fibrinous.
Yeah.
Yeah, because because if you see gross picture as well as the microscopic picture, plus you see the case, right, and see the scenario, and in the scenario it is obvious that we are dealing with Streptococcus beta hemolyticus A type, right? And this streptococcal hemolyticus cause rheumatic fever which involve the heart. So this is how you go through looking at the scenario, looking at the gross picture, looking at the microscopic, and then you correlate. That's why we are calling it CPC. You correlate the scenario with the picture, and then you get this information and go up to the diagnosis. Okay? Clear?
Yes, thank you.
Okay. Any other? Okay, question number 3. Describe the microscopic finding of epicardium. Yes. Almost it is the same, but you have to repeat it.
Just accumulation of fibrin with a little neutrophil.
Neutrophils, not little, it's
More in
more amount of neutrophils
Yes.
mixed with the meshwork of fibrin. That's why it's called fibrinous type of infection. Okay. How does the streptococcal infection induce rheumatic fever? I think we have discussed.
Yeah.
Yes.
Right?
Should I
So,
repeat?
while we were discussing about the pathophysiology, usually there is M protein in the streptococcus, and the antibody usually go and cross react with that the streptococcus, and then this streptococcal antibody
Attack the heart.
cross react with the heart muscle,
Heart muscle.
glycoprotein of the heart muscle. All of the muscles are involved: endocardium, myocardium, and epicardium. So everything has been involved, and finally, what happens? That this rheumatic fever is developed, and more inflammation comes out, right? And it happens. So we are done with this case. Should we move to other one? Okay. Now we are in case number 4. So again, we will start with the first group. Case number 4. Who is going to read? Yeah, go ahead. You want? Yeah. Loudly, so everybody can hear you. Have you on your Zoom?
Yeah, I
Okay,
just
go ahead.
A 37-year-old man has a year-long history of worsening epigastric pain relieved by eating. Upper gastrointestinal endoscopy revealed the gross appearance shown. A biopsy specimen of the interface between the central erosion and the rolled edge has a microscopic appearance also shown.
Okay.
What is the diagnosis on endoscopic view?
What is the endoscopic view showing? By looking at the scenario and looking all the pictures, what is your diagnosis?
It's an ulcer.
It is a
Ulcer.
It's the ulcer. Which ulcer? Is it a duodenal ulcer or gastric ulcer?
Gastric.
Gastric ulcer. Why? Because the patient, it start after eating, right? Okay. What is going on in the microscopic section?
So,
Shedding of the epithelium layer.
You are, who is explaining? Yes, go ahead.
Shedding of all the epithelium layers. And the ulcer.
In the ulcer?
Yeah, shedding of the layers.
shedding. She's saying shedding.
of the epithelium layer.
Shedding.
Yeah.
Okay. Shedding of the epithelium.
Epithelium layer.
So there is no epithelium. It's a discontinuation of the epithelium. That's why we are calling it ulcer.
ulcer.
If it is only superficial removal of the epithelium, that is erosion. Good. Now, then what happens?
So we have the uh, necrotic tissue, and then the second layer will be the polymorphonuclear cells, which is the neutrophils, and then we have the layer of the lymphocyte plus the macrophages, and then we have the granulation layer, which is the blood vessels, neuroformed blood vessels plus fibroblasts.
Good. Anybody wants to add something? No? Okay. So explain the pathophysiology of the disease.
So maybe this necrotic tissue was because of multiple causes. It can be caused by the infection by H. pylori, and it can be caused by the, for example, if someone is taking insects, so the acid will be increased, the mucus will decrease, causing ulcer. And yeah, so basically shedding of the epithelium because of any damage will cause ulcer. And because of the epithelium, necrotic tissue will cause damage associated molecular pattern will cause inflammation.
So basically, it's a imbalance between the acid and the defense of the mucosa, right? It's an imbalance. So imbalance can happen either you have either H. pylori infection, which is almost 80% there, and there should be any other cause like as you said, NSAID or anything else, which can cause ulceration. So which type of ulcer do you see in this one? Any specific? How will you differentiate this ulcer with the malignant ulcer?
Generally, I think malignancy causing hemorrhagic kind of inflammation, hemorrhagic kind of inflammation, like it causes perfusion and then causes the bleeding, and this damage associated molecular pattern will cause the inflammation. I don't think that cancer will cause the inflammation by itself. It will damage and then cause the inflammation, like hemorrhagic.
If you compare these two, this ulcer which you are looking at, right? It's a very clear-cut ulcer, punched out lesion, right? Very much typically a rounded one, right? Smaller one, not more than 0.3 to 0.5 centimeter, and it has a punched out margins. But in a malignant one, they are very much irregular. They are bigger in size, and their margins are heaped up, right? So and irregular. So this is how you differentiate between these two. And what etiology can cause, I think you have already discussed that there are 2-3 things which you have to take care of.
H. pylori insects.
NSAIDs plus
Smoking, yes.
alcohol. So these are important things. And surprisingly, now the smoking, it has been seen in a research that now females are more indulging towards smoking and males are quitting the smoking things. So more and more is transferring from male to female. Okay, so any question online? Yes, yes. This one? This is a pure endoscopic picture. This is a picture of the things which are taken out. It's a gross picture of the biopsy. And this is endoscopic. When you go, you know how endoscopy is done? You pass the tube inside and a camera is there and you visualize. And that's the reason why it is very much shiny here, bubbles. So these are all mucus which you see there, right? And you see this clear-cut margins of the ulcer. And what you do is you do give anti, what you call, you have to decrease this, what you call, yes, proton pump inhibitors. Very good now. Because when we were students, we used to give some other drugs, but now it's a proton pump inhibitors which are usually given now. Okay. Yes.
I want to know in the microscopic picture, what's the difference between ulcer and erosion?
Now, in this, it is clear cut showing ulcer. And if suppose it should be erosion, actually in even here, this is showing ulcer. So in erosion,
And I mean the microscope.
Here, yeah, in erosion, this is clear cut ulcer, but in erosion, it should be just up till here. It should not go, it will not go down up till that much depth. Only, in his stomach, there are multiple layers, 5 or 6 layers of epithelium. So if 1, 2, 3 layer of inflammation are torn down, that is erosion. And if all the epithelial layer are been, it's gone, then it's an ulcer. So now here you can see that no epithelial layer is remaining. In erosion, you can see some of the epithelial remain in the background. Okay. Okay.
Doctor?
Coming to yes.
Isn't this also a perforation or?
No. Perforation. What is? Why you call it perforation? Or what is the definition of perforation?
It cuts through the whole basement membrane and every layer.
Through and through communication of this one viscera to the other one, right?
Yes.
Perforation.
Isn't that the upper right picture the same thing?
But here you can see that a base of the ulcer is visualized. When the base is visualized, means it's not perforation. In perforation, you can see a clear hole through and through. That is a perforation. Okay.
Thank you.
Now coming to question number 5, case number 5, and who is going to discuss case number 5? Kindly read it first. I want some other student to read. You read this case before? Yo. So any from the front area? Yes, go ahead. Little loudly, please. How much loud I am? Right? So be like that. Confident. Yes, go ahead.
She had a mild angioedema, bacillary and hepatomegaly. A chest X-ray showed cardiomegaly and slight arterial enlargement. A few minutes ago, she was briefly admitted to a hospital after she awakened at night feeling short of breath. If she would have died at this point, her heart would have been as shown in autopsy. Describe the appearance of this heart.
What is the difference between autopsy and biopsy? Yes. And this is also, your introduction lecture. So autopsy, when it is done on the dead body, and biopsy when the person is not died, right? Living one. Okay. So describe the appearance of this heart. Yes. Now, you see this one, and you see this one.
Yes.
This is a transverse section, and this is a longitudinal section, right? So what does this both shows? Hypertrophy of right side of the heart.
Yes.
Yes?
Yes.
No,
No.
The left ventricle.
The left side of the heart.
The left ventricle.
Hypertension. Why Okay. How will you define this change?
Increase in the size of cells and increase in muscle fibers because more proteins and more myofilaments are added to the cytoplasm.
Why the cell is not self-multiplying?
Because it's a cardiac muscle. It's a stable. These are stable cells, so they won't. Permanent. Sorry, permanent. Permanent.
Okay, so
they won't cause. It won't.
They will not
hyperinflation. Yeah, they won't multiply.
They will be always in G0 phase. They will never enter in G1. So they are permanent cell. So when they had to increase, it will be increase in the size. And this increase in the size, which thing helps in increasing the size? Yes, you had to have some factors, growth factors, which will increase in accumulation of, yes, some proteins inside. Okay. Question number 2. How many types of are there? Physiological and pathological. So give an example of each. We are talking about hypertrophy because in pregnancy, you're talking about uterus. Yes. Yes, in uterus, we see both of this. It's not only the hypertrophy, but it is also hyperplasia. Why that uterus is doing hyperplasia and not in this cardiac muscle? Huh? Ducts, glands. You're talking about uterus, right? You're and only on hyperplasia. Remember, you're talking about pregnancy. In pregnancy, we are not dealing with the endometrium anymore because whatever function of endometrium it is done. Now the fetus is increasing day by day. Do you see any change in the endometrium? No, there will be no change. So the changes will be in the size of the uterus. So what will you see? Hyperplasia and hyper of the myometrium means why myometrium is been dividing hyperplasia and hypertrophy, and this is it's a smooth muscle. Yes, smooth muscle can divide, skeletal muscle doesn't. Yes, endometrium, remember, we have an endometrial cycle. We have endometrial cycle until the woman is get pregnant, and usually it get pregnant in which state of endometrium? In a secretory phase, not in a proliferative one. So once it has been pregnant, then this thing stops there. The secretory activities goes on. It will not go in proliferation again until the baby is born. Remember, so nothing will happen in the endometrium. It is the myometrium which starts growing up. That is hypertrophy as well hyperplasia. But in cardiac muscle, because it's a permanent cell, it will never enter into G1. So there will be increase in the size by increase in the size by increasing the organ by increasing the size of the muscle.
Okay, so also they contribute in the placenta formation.
Yes, of
So
course.
they go into hyperplasia.
Yeah, but you know we are talking about the size of the uterus. In the size of the uterus, endometrium is not taking any part. Yes. Yeah, because we are talking about hypertrophy, that's why it is. So that is one heart muscle. What is the other one? Physiological muscle. The muscle. You see the muscles of Saad. This is called hypertrophy. Yeah, if you do bodybuilding, you will have this much muscles in your body, right? Okay.
Yeah.
Yes. Pathological. Any pathological finding? Yes. Yes, the same one, right? This is a pathological one. And what is likely explanation of the cardiac finding? Yes. Okay. Hmm. Yeah. So the heart muscle has to work more to push the blood outside. So slowly and gradually, in a time of 10 years, slowly and gradually the size of the heart increases, and this increase is because of the hypertension. Okay. Any question from the class as well as from the online one? Yes, from the class. Do you understand? No, means it's not loud. So you had to be because of necrosis. Which necrosis? Yes, because of arrhythmias. She died of arrhythmias, and there are multiple reasons of arrhythmias. We are not going in detail, right? So when you will come in third year, we have a full case of arrhythmias, and you will then understand how these arrhythmias go and take place, right? So we will not leave these arrhythmias. Yes, it will follow you up till third year, right? So if you are doing your CVP block, we will tell you each and everything, how many arrhythmias are there, what are the factors which are causing arrhythmias, and how the patient is saved and how the patient are died. Okay. Okay. Any question from online? Okay, no question. Question now, case number 6, please. So who will read? Your name? Muhammad. Okay, Muhammad, go ahead.
A 25-year-old is a cigarette smoker with a chronic cough and frequent severe respiratory infection. The microscopic appearance of his bronchial epithelium is shown.
Okay, so this is bronchial epithelium. So on the left side, it's normal looking. Can you explain the normal looking bronchial epithelium? Looking at this slide, normal looking epithelium.
Flattened squamous.
Huh? Which type of epithelium you are looking at?
Squamous epithelium.
Is it?
No. He's speaking about the right side.
I'm talking about the left side.
Oh, left
This
side.
one, a normal epithelium. So go ahead. What is this? Or I am asking somewhere else, somebody else. Yes.
It's a pseudo-stratified columnar ciliated epithelium.
Pseudo-stratified columnar ciliated epithelium. Why it is called pseudo-stratified?
Because it's not many layers. It's only one layer, but the nucleus look like it's stratified, up and down.
Are you clear now?
Yes, with goblet
In
cells.
pseudo-stratified, the columnar epithelium based on a basement membrane. It looks like multi-layer, but actually it is not. They are touching the basement membrane. But if you cut like this, it looks like multiple layers. Multiple layer in the stomach, is it pseudo-stratified? Yeah. No, there is no. Where do you see stratification anymore in other part of the body? Skin is the biggest example. Then esophagus and oral cavity. What about urinary system? They are, but they are not. Which epithelium there? Transitional epithelium, dome-like cells. Okay. Okay. Now, what cellular change has occurred on his bronchial epithelium?
You want to go first? Go first. Okay, so cellular change because of the stress of smoking and chronic cough. In cough and infection, the stratified squamous is better. So the cells will do reprogramming to the stem cells and change the dividing and formation of pseudo-stratified columnar ciliated epithelium into squamous.
Good. So, what's your name?
Al-Walid.
Al-Walid. Do you think that this thing has directly come from pseudo-stratified columnar ciliated to this squamous? It takes little time.
No, it takes time.
So first thing which will you see, what will be the thing?
Into cuboidal or?
Yes, in the cuboidal. So what will you see? Pseudo-stratified columnar ciliated.
Irritation, maybe. Irritation. There will be an irritation to the cilia and the and the columnar cells.
So you will see a loss of cilia. The first change will you see, it will be columnar, pseudo-stratified, but the cilias are gone. and then slowly and gradually you will see mucus gland will be gone, and then this squamous metaplasia will go on, right? And when you stop smoking, if you stop smoking, not a single cigarette for 2 years, then slowly and gradually it will come back. And after 2 years, probably the cilia will also come back. So smoking is so dangerous. And then if something happens, you give all blames to Almighty Allah. Oh, this person was died because, they are not saying that this person was smoking. He is doing himself harmful. If you don't smoke, nothing will happen to you. So you start doing something by yourself, right? Okay, next, how will you define this change?
Metaplasia.
It's a metaplasia. So what is exactly metaplasia is?
Go for it.
Change it
Go on.
one adult cell to
Another cell.
other. So the cells will be adult.
Yeah.
It's not immature. It will be adult. Why I'm emphasizing? Why? Because if it is immature, then it will be
Neoplastic.
it will be then
As a process.
the same thing. This metaplastic process, if the person is still smoking, not stopping this smoking, then this change will go into abnormal one, which is dysplasia.
Dysplasia.
Grading of dysplasia, grade 1, grade 2, grade 3, and then finally cancer.
Well, cancer, yeah.
And cancer, he will say, God. Oh, no, God. It's yourself. You are smoking. Okay. Question number 3. Give 2 examples of this change.
We can talk about Barrett's esophagus.
Yes. So give examples of from columnar to squamous and squamous to columnar.
Okay, so
First of all, columnar to squamous.
columnar squamous.
She is ready.
I can talk about squamous to columnar.
Okay. So I'll come to you from
Okay.
squamous to
Squamous to
columnar.
columnar.
You are telling us from columnar to squamous. Go ahead. In the cervix, what happened? Sorry? Okay. Columnar to squamous. Do you have necessarily HPV, or it will be done before without HPV also? How? Who said that? Raise hand. Yes, yes. Have you heard the word ectropion? What happened in ectropion? Can I write something here?
On the screen?
Yeah.
Yeah, sure.
How can I do that?
With the mouse, you mean? You can write it with the mouse.
Can I?
No, it's not that screen.
No? This one here? No?
No.
Okay, so what happened? Normally, when the female is young, means 13, 14 years, still not crossing the menarche. You know what is menarche? The first menstruation. So in the first menstruation, what happens? That the endocervical tissue, which is bound inside, can you make it here so that I can draw and they can see me?
Sure.
So you just show the camera there.
Yeah.
Okay.
Can you move it there? Yeah.
For example, when it's a little girl, if you talk about the cervix will look like
So can I move a little bit over there? Okay.
So this is cervix, this is endocervix lined by columnar epithelium, right? And this is ectocervix, which is lined by squamous epithelium. After menarche, what happens? The term ectropion, what happens? This endocervical tissue goes out and reach up to here. And squamous epithelium pushes here. Then, because you need to have cervix strong enough to fight with the organisms. You know why we have squamous epithelium on the skin? Because it's very hard. It does not allow the bacteria to enter easily, right? Now it is columnar epithelium. It becomes weak. So this area, normally change from columnar epithelium to squamous epithelium. So this is called transition zone. Although after a few years, if you see, it will be squamous epithelium. It's 12 o'clock.
Yeah.
Okay.
That's okay.
So it will be, you know, columnar epithelium. It will be squamous epithelium, but this squamous epithelium will not be that much strong as the original squamous epithelium. So whatever HPV, now your HPV comes, it has been changed already, metaplasia, but now this squamous epithelium is not that strong as this one, right? So this HPV attacked this area. Okay? Understand? This is actually the process or area where, you know, the HPV attacks. Otherwise, it's normally doing its metaplasia. Okay. Next. Yes, columnar. Now, squamous to columnar.
Yeah, we know if we have GERD, gastroesophageal reflex, we will have more acid going to the esophagus, and we know in the esophagus we have stratified squamous epithelium, and this epithelium is not good to deal with acid, so it will change into columnar, which is better in dealing with acid. So this
What is this esophagus lined by? The whole esophagus.
3 parts. I remember. One certified squamous keratinized, non-keratinized. I'm not sure about that.
Not sure.
Certified squamous.
Stratified squamous. The whole length?
Yes, the whole.
Now remember and bear this thing in mind. The whole length of esophagus is lined by stratified squamous epithelium till the squamocolumnar junction when it enters into the stomach. This is always, you know, I see student making this mistake. Always student making this mistake. Don't do it, okay? The whole length of esophagus is lined by stratified squamous. Now, this is how we help in discussion. So now you will never forget that, you know, squamous, this esophagus is lined by which cell, okay? Now, is this change reversible? Yes, it is reversible. Why and how? How can we reverse this change?
Remove the stress.
Remove the causative agent. Suppose if the person is smoking, stop smoking. Slowly and gradually. 2 years. Remember, if you quit smoking for 2 years' time, then probably in the 3rd year, you might see some of the celias. how dangerous this smoking is. Even shisha. Somebody thinks that shisha is just an entertainment. It is not entertainment. You are injuring your bronchial epithelium as you are smoking. Last question. What additional epithelial change can arise if the causative agent is not removed? Dysplasia. Now, this is an abnormal type of epithelium. Can dysplasia be reversible?
In the beginning.
Hmm? It dependable. If it is grade 1, it can be. Grade 2, yes, it can be. After coming into grade 3, then it will probably not possible. Right? If it is grade 3, then there is a point of no return. Any question from the class as well as from the online students? Now I want to ask this thing now. Do you like this pattern of CPC or you don't like it? Definitely. You will definitely be more, like this thing if the whole class will be here. But we have online students, and I'm sure the online students were also with us, and they were contributing, and I will like to have some contribution from online students also, whether you like the CPC or not, because we were receiving a very good feedback of these CPCs last year, up till last year, but this is a new situation now. So if it is good and helpful for you, although you are sitting online, we'll continue like this. Okay. Yeah, it is different with Dr. Atif, because that was his first time, and actually he was asking me to come and join that. I said we have a full CPC and we will be discussing whole pathology there. So if you want to do, you can do your in 3 different specialty. So thank you very much. And yes, sorry.
He's saying will the answers be posted on Moodle?
Okay, you want me to send this thing in Moodle? Okay, I'll post this answers to the Moodle. Okay, thank you.
Doctor, I have a question.
Oh, thank you very much.
Excuse me, doctor.
All of yes, yes.
I have a question regarding case 4.
Case 4. Okay, what's your question?
Yes, it was talking about gastric ulcer. We said it's a gastric ulcer, but why it's not duodenal ulcer? Because it said in the scenario the pain is relieved by eating.
Can you read the? Let me see the scenario.
The patient has a long history of worsening of gastric pain, relieved by eating.
Yeah, because by eating, what happened that the extra juices which are coming out when you eat something, for a time being, that is been diluted, and the patient will feel little pain rather than having excessive one, right? So this is the reason why she was having that. And then when you do endoscopy, you see these type of ulcer. Okay.
Okay.
Okay. Thank you very much.
Doctor?
Yeah, sorry.
Regarding next CPCs, could we have if you could talk to the university or something, we could have a microphone, because honestly, most of the questions, either the echo was ruining our understanding, or there was no voice.
I will ask Saad to please arrange a microphone here, so that each and every student who is discussing in the class, you people can hear it properly, right? This is what you are asking?
Yes.
Okay. Sir. I'll try my level best to arrange a microphone here,
Thank you.
mic here, so that you can hear this thing clearly. Okay. Thank you very much.
Thank you.
Here.